To understand the pharmacology behind some of these hypertensive medications, it's important to understand the RAAS system. So what happens is when the heart is failing, there's like not enough blood going to the kidneys, and then the kidneys it sends renin to stimulate the liver to produce angiotensinogen, because basically the RAAS wants to increase the blood pressure by vasoconstricting. So what it does is first renin is released by the kidneys, and then the liver releases angiotensinogen and angiotensin 1, and this angiotensin 1, it circulates in the body, and eventually it reaches the lungs, and the lungs releases angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. And what does angiotensin 2 do? So angiotensin 2, for the central nervous system, it increases sympathetic nervous system activity, so like releases things like epinephrine, and then causes vasoconstriction, and then increases like aldosterone secretion. So what is aldosterone? Aldosterone increases the reuptake of sodium, and sodium, like water loves to follow solids, so it follows the sodium, and because of this, there's like a increased blood pressure. So to start with the meds, we have the ACE inhibitor. So that's the angiotensin converting enzyme inhibitors. So what does it do? So angiotensin inhibitors, they inhibit angiotensin 1 from converting into angiotensin 2. And this is found in the lungs. So it basically stops the release of aldosterone. So most of these ACE inhibitors, they end with pril, so I think of eat pril. And these ACE inhibitors, they decrease the preload, afterload, and ventricular remodeling. So basically, it promotes vasodilation and diuresis by decreasing the afterload and preload. And basically, it helps helps the heart with the workload, like decreasing the workload and improving the ventricular emptying. So some side effects would be a dry cough, and also like hyperkalemia, hypotension, renal dysfunction, and angioedema. So for patients who can't tolerate ACE inhibitors due to coughing, they might try ARBs. So ARBs are also known as angiotensin 2 receptor blockers, and a lot of them end with like sartan. So what these do, it has like the same action, like just like decreases preload, afterload, and remodeling, and basically it helps like reduce the workload of the heart and improves like emptying. And some side effects would be hyperkalemia, hypotension, and renal dysfunction, and less of a risk for angioedema. And the next class is beta blockers. So beta blockers, they block the sympathetic influence on the heart by increasing contractility, decreasing cardiac output, and decreasing blood pressure. So it blocks like the RAAS. So selective beta blockers, they only work on the heart and the kidneys, and then non-selective, they only work on the smooth muscles, so like the blood vessels and everything. It's more selective, and this should be avoided in patients who have like respiratory illnesses like asthma or COPD. And then cardiac glycosides. So this is basically like digoxin. So digoxin, it basically, I think of digging your heart, like dig on your heart. So it increases the contractility, but that might slow the heart rate. So make sure to monitor that. And it might trigger like arrhythmias and stuff. And watch out for digoxin toxicity. So monitoring like those lab values. And then finally we have the diuretics. So we have potassium-sparing diuretics and loop diuretics. Potassium-sparing diuretics would be like, for example, spironolactone, that blocks the aldosterone receptor and blocks the sodium-potassium pump. And this decreases the preload and prevents like remodeling. Side effect would be like hyperkalemia. And it's like slower acting too, usually like oral route. And then for loop diuretics, common one is furosemide, and this blocks the reabsorption of sodium from the loop of Henle, and basically makes you pee a lot, and it's like nephrotoxic, and just watch out for like hyperkalemia and hypotension. And these work pretty fast if it's like IV. That's it.